This eHIV review program is presented by DKB Med Radio.
Yeah, I really enjoyed the CROI conference this year. There was an overall feeling of resilience and uplift amongst the HIV clinical and research community, kind of a focus on how do we move forward in the current era of course, against a backdrop of a severe global funding crisis. But I thought it was an excellent conference.
HIV Management Post-CROI 2026. Welcome to eHIV Review. CROI. For 33 years, this forum for scientists and clinical investigators has provided insight into the rapidly shifting HIV treatment landscape. The results of ongoing and newly reported safety and efficacy trials, treatment simplification and ways to avoid pill fatigue, updates on experiments to extend the reach of PrEP, discoveries into the relationships between HIV, hyperlipidemia, and CVD. What do these new advances mean? How can they influence current clinical practice? What breakthroughs may be on the horizon? To discuss these and other questions, we're very pleased to be joined today by one of our longtime program directors, Ethel Weld, MD, PhD, an associate professor of medicine in the Division of Infectious Diseases at the Johns Hopkins University School of Medicine in Baltimore. For our guest disclosures and additional CME information, please go to our website, ehivreview.org, and select the Volume 10, Issue 12 link. I'm Bob Busker, Executive Producer of DKB Med's e-Literature Review video programs. Dr. Weld, thank you for joining us today.
Glad to be here, Bob. Thanks for having me.
Before we begin our discussion, a quick caveat to make sure our learners are aware of much of what we'll be talking about today may not be FDA approved yet. Some may be approved soon, some might not be approved at all. So with that caution in mind, let's get into today's program. Our overall learning objective is to describe the safety and efficacy of newer and investigational treatments for HIV. The focus of this first part of our conversation is on explaining what some of the recent data show about how individuals who are currently virologically suppressed and on complex regimens may be able to switch to newer, simpler ART formulations when they become available. So that said, if you would please, Dr. Weld, start us out in the clinic with a patient scenario.
Okay, so we're going to talk about a case of a 65-year-old man with obesity, prediabetes, and HIV who comes to you to continue care after moving from another city. He's currently on a regimen of ritonavir-boosted darunavir, tenofovir disoproxil fumarate, and emtricitabine. And he's tired of taking multiple pills. He also wonders about ways to optimize his cardiac health, as his brother, who's 11 years younger than him, just had his first heart attack.
A new patient, 65 years old, complains about increasing treatment fatigue maintaining a daily 3-pill regimen, and he's concerned about his cardiovascular health. What are your initial thoughts in this case?
Yeah, so the main thing I'm actually thinking about for him is how to get him off the boosted protease inhibitor, which increases his cardiovascular risk when he's already at increased risk from not only HIV and obesity, but also a family history in a first-degree relative of early MI.
What does the guidance advise when managing a patient like this?
Yes, the first thing is to check a lipid panel every 5 years per the HIV primary care guidelines, or more frequently if it's abnormal. And then after changing ART, consider retesting that 1 to 3 months later. We know from the DAD study that protease inhibitors are bad for lipids, and they may cause some oxidative stress in tissues. Darunavir is probably a bit tougher on lipids than atazanavir. Lopinavir was the worst. But above and beyond that, the American Heart Association recognizes HIV itself as an independent atherosclerotic cardiovascular disease risk enhancer. And we have recent information from the landmark Reprieve trial demonstrating that a statin, pitavastatin, 4 milligrams daily, reduced major adverse cardiovascular events by 35% in people with HIV who were at low to moderate cardiovascular risk over a median follow-up of 5 years. They didn't go on indefinitely, but that's a pretty pronounced effect. So this led to recommendations that were new for the use of statins in people with HIV. And they're now recommended for people with HIV 40 years of age and older, regardless of what that lipid panel told you, and regardless of their ASCVD risk by the risk calculator. So the IAS USA and DHHS guidelines as well both recommend this. The recommendation for a moderate intensity statin for people who are 40 to 75 years of age with a cardiovascular risk of 5% or more is an class A1A recommendation, so the highest grade of recommendation. And there's a lower quality recommendation, class C recommendation, for people who have a risk less than 5%, who have certain risk factors. So there's a little bit of debate once we get into that lower risk category. But overall, the guidance is to consider statins in groups that we previously may not have considered them in if they're living with HIV.
You mentioned the DAD study, the DAD study, which stands for Data Collection on Adverse Events of Anti-HIV Drugs.
The DAD study was the one that first established, really, that each year of cumulative protease inhibitor use was associated with a 10% greater risk of myocardial infarction. So that's even after adjusting for the cholesterol and lipid changes that were caused by protease inhibitors.
Those are the results of the initial 2018 study. What's important for our learners to know about the 2025 DAD follow-up?
Yeah, the more recent findings, the DAD 2025 study is just kind of covering the later protease inhibitors, still found harm with cumulative use of ritonavir-boosted darunavir with really progressive increase in cardiovascular disease risk with a increased incidence of 1.59 per 5 years of additional use, whereas ritonavir boosted or unboosted atazanavir showed no association with increased risk in that study. But the incidence rate of cardiovascular disease definitely did increase in those exposed to darunavir compared to those not exposed to darunavir. And the other thing is we have to keep in mind that there can be severe side effects associated with some of these complex regimens involving PIs, particularly like constant diarrhea, et cetera, from the protease inhibitors. And people may be on them because they feel they have no other choice. So talking with him about how to expand his options and his choice is definitely warranted.
So to reduce his cardiovascular risk, what other new regimens might he be an appropriate candidate for?
Yeah, so I think looking at some more recent trials, I think the Artistry-1 trial showed us that he might eventually be a candidate for the two-drug regimen bictegravir and lenacapavir once a day. And this is not yet approved, but is in late-stage testing and probably will emerge onto the market soon. And that study included people like him who were suppressed. Their viral load was less than 50 copies per mil for 6 months, and they were on a stable regimen. And these were people on complex regimens defined as containing a boosted PI or non-nucleoside reverse transcriptase inhibitor, plus another agent from a class other than NRTIs. Or they're on a regimen containing multiple pills a day or requiring dosing more than one time daily, et cetera. So these were some of the ways they determined whether a regimen was complex and whether the person would qualify for the study. And then they took this group and they randomized them 2-to-1 to receive bictegravir, 75 milligrams, plus lenacapavir, 50 milligrams once daily, or to continue with their complex ART regimen, the one they were on before the study, for at least 24 weeks.
Before I ask you about the Artistry-1 findings, What else should we know about the individuals enrolled in this trial? Population, age, length of time on treatment, that sort of thing.
In this group of people who were on average middle-aged, about 60 years old, most of them had been on HIV treatment for at least 30 years. So these are people who've been treated since the very beginning of the epidemic and have been through every suboptimal treatment regimen of the early years of treating HIV. They were taking a median of 3 antiretroviral pills per day with a range of up to 11 pills per day.
And the findings in that trial.
What they found was that at week 48, viral suppression, less than 50 copies per ml, was observed in 99% of the participants receiving bictegravir-lenacapavir, and also in 99% of the participants receiving a complex regimen. So that met their pre-specified definition of non-inferiority, which would have been a difference of 4%. They seemed comparable and non-inferior. No resistance was seen in this study, so switching to this 2-drug regimen did not result in people acquiring resistance or having failure. And people had approximately similar safety. Adverse event rates were similar between the two groups with a similar rate of discontinuations. And there were some deaths in the bictegravir-lenacapavir group, but none of them were deemed to be related to the study drug. They asked them about their treatment satisfaction, remembering that some of these individuals were on very high pill burden, cumbersome treatment regimens. And after switching to bictegravir-lenacapavir, they reported increased treatment satisfaction in the majority of cases. So overall, that was reassuring data showing that the options for this group of patients who have patiently been surviving through the most difficult eras of treating HIV may stand to have their options considerably expanded soon.
That's a very exciting finding, Doctor. Are there other regimens that you might consider?
Yeah, well, speaking of lenacapavir, there's one more promising lenacapavir combination that is not yet ready for approval, but that is a once weekly combination of lenacapavir, 300 milligrams, and islatravir, 2 milligrams. And that's also being investigated in a phase 3 trial after showing highly promising results in the phase 2. It's important to note that this drug, islatravir, in some other studies, including PrEP studies, actually had shown some decreases in lymphocyte count, which led to a clinical hold being placed on those trials by the FDA. But now with this lower dose of islatravir in this once weekly combination, no concerning decreases in lymphocytes were seen. And so this expands us into the territory of long-acting oral regimens. So regimens that are pills, but don't have to be taken daily. And for some people, that fits in better to their schedule and is more tolerable for them than the daily incursion into their life of taking a pill once every day.
So a number of very promising regimens that can't be accessed right now because they're not yet FDA approved. What can you tell our learners about treatment regimens available right now that this patient might benefit from?
Well, I think you would probably do just fine on bictegravir, tenofovir, alafenamide, FTC fixed dose combination based on some recent studies, one of them in Haiti that showed non-inferior virologic efficacy of BIC-TAF FTC in people who had experienced virologic failure on second-line regimens, such as these complex regimens, and they compared that to just staying on the complex regimen. And they did just as well on the BIC-TAF FTC. We also know from the Dawning study, which was done a few years back, that dolutegravir plus 2 NRTIs was superior to ritonavir-boosted lopinavir plus 2 NRTIs as second-line therapy in people with HIV who had experienced virologic failure and had some degree of NRTI resistance. So this is reassuring that the integrase strand transfer inhibitors can be useful in this context. And the Dawning study was the first major study supporting a regimen other than one based on a boosted protease inhibitor for second-line antiretroviral therapy. And also the Nadia trial showed that even in people on second-line regimens who were failing those regimens with a viral load greater than 1,000 copies per ml, which is what's defined by the WHO as failure, who had significant NRTI resistance, not just a M184V here or there, but sometimes extensive tenofovir resistance. A regimen of the second generation INSTI dolutegravir plus 2 NRTIs was non-inferior to a boosted darunavir-based regimen. So that's important information that these INSTIs can be quite helpful in a pinch, even for people on complex regimens.
Thank you, Dr. Weld, for this wide-ranging, data-driven conversation. Our key learning focus for this part of our discussion is to explain what the recent data show about how individuals currently virologically suppressed on complex regimens may benefit from switching to newer ART formulations when they become available. What are the most important things our learners need to understand about this topic?
I think the first thing to remember is that protease inhibitor-based regimens do carry an increased risk of adverse cardiovascular outcomes, and considering switching away from them, particularly in individuals who already have an elevated risk of cardiovascular disease, is worthwhile. I think the second point is that in those who are virologically suppressed on complex regimens, based on the data from Artistry-1, daily oral single pill bictegravir with lenacapavir has been shown to be non-inferior to staying on those complex existing therapies over the course of a year. And then also that there's good data for switching people on complex regimens to INSTI-based regimens, other INSTI-based regimens, plus 2 NRTIs, even when there is significant NRTI resistance present. So that's a 3-drug regimen approach as compared to this 2-drug regimen of bictegravir, lenacapavir alone.
Nice summation, Doctor. And we'll return with Dr. Ethel Weld from Johns Hopkins in just a moment. Providing the best care for your patients takes more than identifying the most relevant information. It takes expert opinion and analysis of the data, combined with expert advice about how to most effectively put that information into practice. It takes the Johns Hopkins University School of Medicine e-literature reviews. Top experts in their specialties, selecting the most important peer-reviewed literature, analyzing the information, and explaining what it can mean to clinical practice. E-literature reviews, independent medical education, CME, certified by Johns Hopkins University School of Medicine, and presented without charge by DKB Med. Welcome back to today's eHIV review program. Our guest is Dr. Ethel Weld, an associate professor of medicine in the Division of Infectious Diseases at the Johns Hopkins University School of Medicine in Baltimore. Our overall learning objective is to describe the safety and efficacy of newer and investigational treatments for HIV. Our first case of today's discussion focused on what the recent data have shown about how individuals currently virologically suppressed on complex regimens may benefit from switching to newer ART formulations when they become available. Let's turn now to the second focus of today's conversation. Describe the evidence surrounding the long-acting complete antiviral regimens of cabotegravir and ripivirine, currently FDA approved for the treatment of individuals with viral suppression, but increasingly being started off-label for people with viremia. So take us back to the clinic now, if you would please, Dr. Weld.
Sure. So let's talk about a 35-year-old woman with hypothyroidism, depression, and HIV who has struggled in the past to adhere to oral ART regimens, who comes to see you in clinic. She tells you that she feels reminded of the traumatic circumstances of her HIV acquisition whenever she takes oral pills, and they also stick in her throat and give her reflux, and she finds it intolerable to swallow them. However, for the past 4 months, she has been making a concerted effort to adhere to them every day and has managed to adhere to this regimen of dolutegravir plus taf-FTC daily with very few missed pills. And she is now virally suppressed and has been for the past few months. So she has intermittent adherence in her past, but her recent past, she's been suppressed. She asks about getting her HIV medicine as a shot, and she would like to know how risky that would be for her.
As you listen to this patient, what's going through your mind? How are you going to advise her?
Well, first, I want her to understand that we now live in a world where there are options, and these options are increasing every day. I want to reassure her of that and let her know that she's not alone in having struggled in the past to adhere to daily oral regimens of pills. A third of adults in the US who have HIV are not virally suppressed. So that's 1 in 3. And often this is due to challenges taking oral, daily, lifelong pills, like the challenges she's experiencing.
Understood. But she's specifically asking you about the safety of switching from her current daily oral regimen to long-acting injectable ART. Which of the findings from the more recent trials would you want her to be aware of?
Yeah, so I think I would discuss with her the findings from the Impala trial, which looked at injectable cabotegravir and rilpivirine in a cohort of patients like her who had HIV and had achieved only intermittent adherence in the past. So at study initiation, they were first asked to take oral ART for 3 months with lots of wraparound adherence supports, so text and phone reminders. And if they then achieved suppression, they were randomized to either stay on that regimen or switch to injectable bi-monthly, so every 8-week cab rilpivirine intramuscular injections. So this is a similar design to the Latitude trial, the ACTG 5359 study, which looked at once monthly cabotegravir rilpivirine instead in a similar group of people. So I'd tell her more about the Impala trial results, which were presented at IAS 2025 in Rwanda this past year. And it showed that injectable cab rilpivirine was non-inferior to standard oral therapy at 48 weeks in the setting of sub-Saharan Africa, which was where that study was done. So they saw virologic suppression at 48 weeks in around 90% of participants in both groups. Interestingly, in a pre-specified sensitivity analysis, having an HIV viral load greater than 1,000 copies per ml at any point during the study follow-up was significantly less commonly observed in the cab rilpivirine recipients than in those who received oral ART. And I'd also tell her about data from the SUPLA trial in Taiwan, which was presented at CROI in 2026, a few months ago. So they randomized individuals with adherence struggles and baseline viremia, so people who were not suppressed, to either cabrilpivirine or continuation of their prescribed oral standard of care ART. They actually found superiority of the cabrilpivirine regimen in attaining viral suppression at 6 months. And very importantly, 60% of the SUPLA study population reported substance use. Over half had been out of care and lost to follow-up at the start of the study for sometimes years, but all were successfully re-engaged by the promise of long-acting bi-monthly HIV treatment. So this was extremely significant because it represented engaging people in care who were not currently in care because of the difficulty adhering to oral ART. And I think set a valuable example for how we can help our patients.
That's a lot of good information from the SUPLA trial. Anything else?
They also reported lower stigma scores. So this study team went ahead and measured stigma and reported that the participants had lower stigma scores after switching to an injectable regimen.
Interesting, Doctor. Thank you. A couple of other things we haven't touched on yet, Dr. Weld. One is resistance to either of the agents in a long-acting regimen.
Well, most of these trials excluded people with active hepatitis B or with significant resistance to one or the other components of the regimen. I usually do a baseline genotype, but it would be difficult to get one in this patient now that she is suppressed. If we don't have reason to believe she has resistance to any of her past regimens, for example, periods of intermittent viremia while on an oral regimen like a rilpivirine containing one that has a low barrier to resistance. If she doesn't have that, it's reasonable to start CAB rilpivirine in this virally suppressed patient.
You brought up hepatitis B. What if a patient does have a Hep B infection?
Yeah, so a hepatitis B testing panel is important before beginning a treatment such as this, as neither component of this regimen covers hepatitis B. You'd have to have a regimen containing tenofovir disoproxil fumarate or TAF combined with emtricitabine or FTC. This regimen does not include that. But there's also a critical point, which is that vaccination against hepatitis B is critical for people with HIV. So everyone that you're following for HIV, regardless of which regimen they're on, should be vaccinated against hepatitis B. The Impala trial did, in this high prevalence for hepatitis B area, have 31% of its participants who had hepatitis B virus E antibody positive, which indicates a past cleared hepatitis B infection. And only a single participant got a new hepatitis B infection while on cabrilpivirine and was switched off that injectable regimen onto tenofovir, lamivudine, dolutegravir to treat both viruses.
Now, talk to us, if you would, please, about the risk of virologic failure on a cabrilpivirine injectable regimen.
Yeah, so there's a fairly consistent rate of confirmed virologic failure, which can be defined in somewhat different ways in different settings in people who are on cabotegravir and rilpivirine, even among individuals who start out with viral suppression. And that rate is about 1% to 2% consistently across trials and real world settings among those who start out suppressed. And whenever I start this regimen, I feel it's important to discuss that risk with the patient and discuss the important benefits of coming in on time for all of her injections. So that's the adherence equivalent of this injectable regimen. Whereas for taking a daily pill regimen, you have to ingest a pill every day. For taking an injectable regimen, you have to come in within your treatment ideal window for that repeat injection. The US-based OPERA cohort looked at about 5,000 individuals who'd been started on cabrilpivirine and looked at outcomes with every 2-month cabrilpivirine, comparing people whose initial viral load was above 50, so were not suppressed, to those whose initial viral load was less than 50. And 95% of those who were suppressed had a most recent viral load that was still suppressed at the end of follow-up, but only 79% of those who had an initial viremia had a suppressed viral load less than 50 at the end of follow-up. The rate of official confirmed virologic failure was 1% in the people with suppressed viral load at baseline versus 2% in the people with initial viral load over 50 copies per ml. So in both of those groups in the OPERA cohort, there was a low rate of confirmed virologic failure. But I did want to mention a similar study that was presented at CROI 2026 by our wonderful colleague, Dr. Matt Spinelli from UCSF, who's another eHIV review program director, who looked at 2 large US clinical cohorts of people with HIV in San Francisco and Atlanta, around 1,000 people in total, and found that while virologic failure was uncommon overall, it did seem to occur more frequently among individuals who initiated cabrilpivirine with viral loads over 50, compared to those who were already suppressed at the time of initiation, with a risk of failure of 6% among the viremics at initiation compared to 1% among those who were suppressed at initiation. And in addition, both isolated viral blips of greater than 50 copies per ml and more persistent low-level viremia, so not just a blip that goes up and then comes back down to suppressed, but is consistently high, were more common among people who initiated that injectable therapy while viremic. And the last, important thing to touch on is that having a blip or persistent low-level viremia was associated with a slightly higher likelihood of later developing virologic failure. Nonetheless, 96%, so the vast majority of those with viremia, did rapidly suppress to under 50 copies per ml on long-acting ART at a median of 4 weeks from initiation. So this is quite rapid suppression.
Thank you, Dr. Weld. Our key learning focus for this part of our discussion is to describe the evidence surrounding the long-acting complete antiviral regimens of cabotegravir and rilpivirine, currently FDA approved for the treatment of individuals with viral suppression, but increasingly being started off-label for people with viremia. Dr. Weld, what are the key things you want our learners to take away from this part of our discussion?
I think the first thing is that the Impala and Latitude trials showed that long-acting ART can be successful in engaging individuals with adherence struggles who have suboptimal virologic control, particularly if they're able to suppress on oral medicines before transitioning to injectables. But there is a low rate of virologic failure in people who initiated rilpivirine while virologically suppressed of around 1 to 2%. And furthermore, there's a prevalence of low-level viremia, defined as viral loads between 50 and 200 copies, among people on long-acting ART, which is still being figured out, but in some cohorts can be associated with going on to later virologic failure. And then lastly, I think it's important to remember that long-acting injectable ART can be helpful for people who have pill aversion, like our patient, and stigma surrounding their HIV diagnosis, and really struggle to take pills every day.
From the Division of Infectious Diseases at the Johns Hopkins University School of Medicine, Associate Professor of Medicine, Dr. Ethel Weld, thank you for sharing your knowledge and expertise with us in today's eHIV review program.
My pleasure, Bob. Thanks so much for having me. I felt like it was a great wide-ranging discussion, and all of this is important information as we prepare for the future of HIV management, including how to present emerging evidence to our patients and how to one day incorporate it into their care. So thank you.
For eHIV Review, I'm Bob Busker.